Hello, this is Dr. Alex Daves, and this is part one of a three-part lecture series in the basics of ultrasound, particularly at Mountain View Hospital Sunrise GME in Las Vegas, Nevada. These are going to be available online, and a lot of these are going to sort of cross over and might be relevant to pretty much anyone. So if you're watching this from somewhere else, welcome. And for those of you who are in the Sunrise GME Consortium, here's here's going to be our introduction to ultrasound. So this first lecture is about the fundamentals of ultrasound physics and equipment. I feel like this is a really important topic to get a firm grasp on before we move on to other more specific topics, just because I feel like if you understand the physics of how ultrasound works, it makes the machine and the equipment make a lot more sense when you're using it. So obviously disclosures, I have none. Now, the objectives of this lecture, we're going to learn the basics of ultrasound as a modality, we're going to discuss imaging modes and their uses, and we're going to learn about different types of imaging artifacts on ultrasound. So, why point of care ultrasound? There's a bunch of reasons why, but they're really summarized in this really cool acronym that I found earlier on. It was POCUS is a physiological study, on-the-spot clinical decision tool, clinical examination extension, unique and expanding tool, safe and repeatable. And this sort of sums up really neatly why we use point-of-care ultrasound. It's something that we can take to the patient's bedside that makes a difference in their care, and that we can do over and over again if the patient changes or deteriorates, and it's safe, and it's something that's easy to teach and very approachable. So, what makes ultrasound ultrasound? That's frequency. So remember that frequency is wave speed divided by wavelength. So that's sort of indicated by this graph here. You might have seen this if you've seen any lectures about ultrasound physics at all. And then that gets translated into tissue basically by having expansion and contraction rather of molecules, substances, whatever, and those will in turn reflect some of these waves back to the transducer, which we'll talk about in a minute. The transducer itself functions through what's called the piezoelectric effect. So that means that the ultrasound machine sends a pulse of electricity into the probe. The probe converts this electricity into a vibration of a crystal that then creates a sound wave. Then the machine shuts off the electricity. Some of those sound waves reflect back, and they cause the crystal rather to vibrate when it comes back. That vibration then creates an electrical current which gets transmitted up the wire back to the machine. So in this way, it uses the same effect both to create sound and then to create electricity, the electric signals rather that the machine interprets. And as I just mentioned, the ultrasound machine functions in pulses, so it sends out signal and then it waits. It sends out signal and it waits, and it keeps repeating that as long as the probe is active. There can be up to 1,000 pulses a second, depending on what imaging mode and what specific settings you have on. And then as far as the machine is concerned, the speed of sound is always 1540 meters a second. That will be more important in some later lectures here. So the ultrasound machine itself basically creates a graphical display of reflected sound waves. So its basic function, like any other form of imaging, it creates a 2D representation of a three-dimensional object. And in the ultrasound's case, it converts that sound signal into visual data. Now, it's important to remember that the ultrasound machine actually scans through the crystal while it's active. So rather than having the entire crystal active at once, the machine goes from one side of the crystal to the other. Now the power doesn't immediately drop to zero. There's some residual ultrasound beam forming behind and in front of the main beam, so that can cause some different artifacts that can be important later on. And this is what that looks like. So essentially you have your main beam is this one right here. And then you have side beams, these ones are powering down and these ones are powering up. And all of that is, comes into play. So in terms of what we talk about when we see something on the screen, we refer to those as echoes. So that's because that's what causes the graphical representation is the sound waves put out, it bounces off of something, echoes back, and then that gets displayed on the screen. So strong echoes are displayed on the screen as being brighter or wider, also often termed hyperechoic or echogenic. And by strong, I of course mean basically louder. And then weaker or quieter echoes are displayed on the screen as darker or blacker, are often termed hypoechoic or anechoic. So in these instances here, this line, this bone here, would be a hyperechoic or echogenic substance, and then this here, the urine inside the bladder, would be an anechoic or hypoechoic substance. And the other thing to keep in mind is what's called signal attenuation. So echoes from deeper tissues are quieter than more superficial tissues. So the machine has to sort of listen harder as the echoes get further away, which increases noise relative to signal. Here's an example of that. So you can see the everything that's up in the top part of the screen is really nice and bright and really sharp. And as you get further away, it gets less and less clear. And that's due to signal attenuation. So in radiology, the ultrasound machine is on the patient's right and the probe is held in the right hand. But in cardiology, the ultrasound machine is on the patient's left and the probe is held in the left hand. So in the point of care space, our waters are muddied a little bit. Obviously, procedures require the use of the non-dominant, usually the left hand, holding the probes. The dominant hand can hold the needle. But my belief is that consistency is more important. So we generally adopt the radiology conventions for both machine side and probe holding. But at the end of the day, if you're in a crowded resuscitation or a trauma, all bets are off. You just get your images. The probe is marked with an indicator, which matches the indicator seen on the screen. So generally speaking, your usual orientation is going to be with this indicator right here. And that's the indicator on the body of the probe. Some probes have some special markings on the head of the probe, but we're paying attention mainly to the indicator on the body of the probe. So in general, if you are in the sagittal orientation, the probe indicator should face superior on the patient, and in the transverse orientation, it should be to the patient's right side. But again, this can depend on your indication. There's a bunch of different exceptions to that, but that's just a general rule. So the indicator on the screen is typically in the upper left corner, except in cardiac imaging, which is in the upper right, and then sometimes ped cardiac imaging is in the lower right. And those indicators can look like a variety of things. So there's a GE, there's a Sonosite, there's a Philips, and here's another GE. And what you're looking for is this here is the indicator, is the screen indicator, here's a screen indicator, here's a screen indicator, here's a screen indicator. So they can all look totally different, and it's just important to familiarize yourself when you first use the machine of what the indicator looks like so that you know what to look for. In terms of probe movement, I prefer to use the terms that were standardized by Dave Boehner et al. In 2016, and those basically being that you have sliding, which is movement in the long axis of the probe, which looks like this, so it's towards or away from the indicator. You also have rocking, which is rotational movement in that same long axis of the probe. You can have sweeping, which is a motion in the short axis of the probe that looks like this, basically like you're taking the probe and using it like a broom. Fanning, which has a rotational movement in that short axis of the probe. And then, generally when we're referring to just simply rotating the probe, we usually use hands to the clock. So say like rotate to 10, rotate to 2 o'clock, that sort of thing. So as discussed, frequency is what's important to make ultrasound. So in diagnostic ultrasound, the frequencies are generally in the 1 to 20 megahertz range. Traditionally, some probes go slower than that. Usually it's your high frequency ones that get up to that higher limit. And what that really does for you is that makes a big difference in terms of how deep the tissues penetrate. So lower frequencies travel further and they produce echoes from deeper tissues. So here you have an example of, this is a cardiac ultrasound using a phased array probe. The depth over here, it's down to 20 centimeters, and you're getting really good image resolution for the vast majority of the screen, right? Like this is, everywhere that you're looking and you can see everything super clear. On the other hand, this first few centimeters up here isn't super clear. I don't really know what's going on there. And that's one of the downsides of having one of those low frequency transducers is that they just don't get very good resolution in the near field. Those higher frequencies, on the other hand, will give you really good resolution in the near field. So here's an example of a linear probe. This is looking at an ankle, actually, and this is only 4 centimeters deep, but you're getting a lot of really useful information in those 4 centimeters. And you can see it's at a much higher frequency than the other one. So this is one of the reasons why we use frequency to our advantage in order to make a determination and use what type of probe we need to use for what indication. So we're going to talk a little bit about what type of imaging modes are available for the ultrasound machine. So their default, the one that everyone knows, is B mode. It's called brightness. Sometimes it's what you consider the default scanning, your live imaging. Sometimes called 2D. That's sort of your home base in terms of imaging with the machine. There's also a mode called amplitude that's primarily used in opto. Not really anything else for us to know about that in the point of care space. You have M mode or motion mode that shows changes over time at a specific line in the B mode image, and we'll show an example of that. Some machines are also equipped with a retrospective M mode called anatomic M mode. We're not going to go into that because it's In my experience, it's a GE specific thing, but it is a really useful tool. And if you have anatomic M mode available, I advise that you play around with it and get some experience with it. It's very useful. You also have color Doppler, which shows sort of qualitative movement towards or away from the transducer. Generally speaking, red is towards and blue is away on most machines, but there's always a scale visible that I'll show you on one of the slides here. And you always want to check that scale before you decide which way direction is which. Power Doppler shows the same kind of information. It shows qualitative movement, but without direction. The advantage is that it is more sensitive than color Doppler, so that's one of the reasons why you might use it, is color Doppler not getting you enough information. So those are the non-spectral Dopplers. The spectral Doppler, which is like quantitative Doppler. There's pulse wave Doppler, which shows quantitative movement towards or away from the transducer at a gated location. It is known to increase heat energy transmitted to the interrogated structure, so it's not supposed to be used in, for example, first trimester OB scans or anytime you don't want to heat whatever tissue you are interrogating. And then continuous Doppler shows movement in an interrogated plane. So it's actually more commonly used in handheld Doppler machines, such as this one right here. So your vascular OB probes, those are dedicated continuous Doppler machines that convert the sound to louder non-ultrasound sound, whereas if you're doing it on an ultrasound machine, it's converting it to a visual representation. And the energy transmission of continuous Doppler is similar to M mode, so it is safe for use in pregnancy. And then I always caveat this lecture just saying that pulse wave Doppler and continuous Doppler I don't typically teach to residents because there's some complexity involved, and most of our point of care scans don't really require it. So my preference is, for any residents who might be listening, that you get really, really good at all of our core modalities before you try to move into the world of spectral Doppler. So here's an example of B mode or brightness mode. And you can see it is just a black and white representation of whatever the probe sees underneath it in the tissue. This is an example of M mode or motion mode. So in this case, you can see that it's following this line, the line visible in the top image up here, and it's looking at this whole area right here, and it's translating that line by line. It's transmitting a little bit here, and then here, and then here, and it just kind of keeps adding a line and just keeps going until it has this full image where you have a representation of what changes have happened at that line over time. So this is a color Doppler image. And you can see the scale that I mentioned earlier off to the right side. It's on every single one of your machines. So always just look at it to determine which direction the flow is going rather than trying to make a determination off of memory. This is power Doppler. And as you may notice, there's no direction on this because it doesn't know which direction. It sacrifices the direction information in order to increase sensitivity. This is continuous Doppler, and there's a few things to note in order to be able to differentiate what continuous is versus what pulse wave is. So continuous Doppler really only knows the max and mins at any given time. So you'll see this looks like this, where it's these towers that are completely full. There's no black spots inside of them because the machine doesn't know if anything's going this speed. It just knows that something's going as fast as this and as slow as this, or as fast towards the probe this way and as fast away from the probe this way. It doesn't know anything else in between. The other difference is going to be your velocity, because the velocities go much, much higher on continuous Doppler than they do on pulse wave Doppler. They have much higher Nyquist limits traditionally. Speaking of pulse wave Doppler, so this is what pulse wave Doppler looks like, and you can see they've got these black zones and black triangles inside of the waves. That indicates that the machine knows that at this particular moment nothing is moving this speed away from the transducer. And then you can see the limits here are much lower than what you were seeing before. So that's one of the ways to tell the difference between the two. So the machine has to make some assumptions in order to function at all. And we're going to talk about those assumptions and then what happens when those assumptions are broken. So one of the assumptions is that pulses and echoes travel along a straight path. Echoes return to the transducer after one reflection. Echoes originate from the main transducer beam. Pulses and echoes are attenuated uniformly by all tissues, and echoes travel at a uniform speed, which is that 1540 meters per second I mentioned earlier. So when those assumptions by the machine are broken, you get what's called an artifact. An artifact is a representation on the screen of some physiologic thing that is not actually true to the anatomy that's actually there. And there's tons and tons of these artifacts, and if you want a comprehensive list, there's a really good one on radiopata.org that I've cited in my in my references that you can take a look at if you want to look at a more comprehensive list of artifacts. Here I have a few of them listed that I think are really important to know in the point of care space, but it's not a comprehensive list. So the first one is aliasing, and that's a Doppler specific type of artifact, and that is when an error in machine setting basically leads to the machine's inability to record direction and velocity accurately. We have mirror image or refraction. So that's when ultrasound strikes an interface at a non-perpendicular angle, which can strike a reflector and turn to the probe, generating a double image, or can strike nothing, and then you have loss of the signal from that area, creating more or less a black line on the screen. You have a reverberation, and that occurs when an ultrasound beam encounters two strong parallel reflectors. You also have posterior enhancement, and that is when echoes returning deep to a fluid-filled structure have less attenuation, and thus the echoes return stronger, causing increased local brightness. And you also have shadowing. So that's a signal void that's caused by structures that strongly absorb or reflect ultrasound waves due to a sudden change in ultrasound velocity propagation. And there's two types of shadowing to be aware of. There's clean shadowing. This is what's normally traditionally thought of as shadowing, and that's where you have like either a bone or a gallstone or a kidney stone or something else, where you have this hyperechoic line of the reflection followed immediately by a dense anechoic signal void. The other type is the dirty, and that's sonographic signature of air. So that's basically a hyperechoic reflection line that progressively becomes less echogenic over time, or rather as you go deeper into the tissue. So this is an example of shadowing. You have a high density object that reflects the sound waves that causes loss of signal deep to the object. So this is clean shadowing, which is noted with like gallstones, bones, kidney stones, that sort of thing. And that artifact is, here's the stone right here, and you can see the shadowing behind it. So here's another example of shadowing. In this case, gallstones are completely filling the gallbladder, and you can't see the lumen at all, but it makes a really good example of you have this bright white line right at the top, and this dense shadowing behind it, where you really can't see anything. So this is an example of posterior enhancement. Like I mentioned earlier, sound is transmitted more efficiently in fluid than soft tissue. It loses less signal as it returns back. So anything deep to a fluid-filled structure will be brighter or more echogenic than it would be otherwise. So usually like urinary bladder, cysts, abscesses, hematomas, effusions, eyes, all these things can cause it. But here you have this area down here that's really, really bright compared to the area that, for example, didn't have a fluid-filled structure. And that is an example of posterior enhancement. This is another example of posterior enhancement, but there's some other artifacts here as well. So you actually have a little bit of air artifact right here and right here. So air here, and then right here as well. And that's a reverberation type artifact. And you can see it kind of starts echogenic and then gets progressively less echogenic as it goes further in due to the reverberations getting a little quieter. This is a mirror image or a refraction type artifact. So the images are duplicated on the other side of a strong reflector. So basically the sound waves come in and get refracted off, but then it bounces off of the reflector and comes back to the probe. And that's why you see this structure mirrored across the diaphragm. So the diaphragm is the main structure that does this. And just to be aware, if you're trying to tell the real structure from the duplicated one, the farther image is always the duplicated one. So in this case, this one's the closer one, so it's real. This one's farther, so it's the duplication. This is another example of air, and this is right over here. And this is probably the duodenum. So you see, again, it starts off really bright, and it gets a little less bright, and a little less bright, and a little less bright, and then eventually becomes dark or anechoic, and that's the sonographic signature of air, that dirty type shadowing. And some normal areas to see air would be like the pleural interface or like smaller large bowel, you could see air. This is another example of abnormal air artifact. This is actually in an abnormal location. So this is the air artifact right here. It's pretty clear. And this is actually coming down over the liver. So this is pneumoperitoneum. But there's another example over here of some more air artifact as well. So this is a reverberation artifact. In this case, these are pulmonary B-lines. It's caused by a few different things. It has high acoustic impedance, ultrasound waves, combination of air and water that causes continuous signal return to the probes. The beam comes down here, it hits right here, and the reverberation caused there to be just signals continuously returning back over time to the probe, which the probe can't tell, that there's a difference in time except that to draw it further down. So that's why you end up having this artifact that extends to the bottom of the screen. Here's an example of some B lines in a patient. And then here's an example of more like a Z-line or a comet tail. It's also a reverberation type of artifact, but it's much more limited due to the, thought to be due to the amount of actual fluid that's there. These actually don't erase A lines, so keep in mind if you see something like this is not a B line. And then this is sort of another type of refraction artifact. So some of the edges of solid organs, deflect rather than reflect sound waves. So it produces shadows from the edge of the refractor if there's no reflector. It's not as well understood as we originally thought. It could be multifactorial in origin, but that's the general thought behind it. But here you have basically the ultrasound wave comes down here and actually refracts off, so you don't get any information. The machine gets no information from this part due to the ultrasound waves not returning, and that's what causes that artifact. Now this is aliasing, and this is aliasing on non-spectral Dopplers. This is color Doppler, and you see this mixing of color in the image, basically that really scrambles the direction information. Basically, all you can really tell is that the settings are wrong. Usually it's due to exceeding the Nyquist limit, but sometimes it can be due to undersampling as well, which is a incorrect pulse repetition frequency. So those are the two reasons why you can end up having this aliasing artifact. This is another example of aliasing, but with pulse wave Doppler. So you can see like right here, this is cut off. This is cut off. This is mostly present, but it is still a little bit cut off. This is cut off. So that's what aliasing looks like on a pulse wave Doppler image. So in summary, point-of-care ultrasound is a very useful clinical tool. Ultrasound works by interpreting reflected sound waves into a picture that we then interpret into a clinical, meaningful representation. Each imaging mode adds another layer, and artifacts result from machine errors, but actually can still be interpretable and provide useful information. And here are my references.